Well, we're so grateful that you could be here with us for our first CME conference for pediatric rural healthcare. We're proud of our alliance with Children's Healthcare of Atlanta and so proud of the opportunities that they have opened up for us to be able to offer this for rural Georgia. You here today are the heart of it. You're at the heart of everything that we do because you are out there serving, taking care of, raising the future of rural healthcare. And so because of you and because of what you're doing today and in the future, rural Georgia will be healthier. And when you listen to people on the television shows and even sometimes under the dome, they'll lead you to believe that rural Georgia, nobody wants to be there and it's dying and it's not a good place. And we're here to say, hey, wait a minute. We are those people. We were born and raised in rural Georgia. We choose to stay there. But we also believe that because of your zip code, you shouldn't have to compromise in care. And so we're out there every day doing that work to make rural healthcare better. And that's, we're so grateful to you because we know you fight that fight every day. And we're so grateful to our partners at Children's for allowing us to be able to come in and do that work and supporting us and coming along behind us to say, you guys are really important and the work that you do is very important. So we're grateful for Children's. We're grateful that you're here today. I think we're going to have a great day. And so with that, I'll turn it over to Pam Mason.
Oh, they took my picture from LinkedIn. That was a few years back. So I'm Pam Mason. I am the Director of Affiliations from Children's Healthcare of Atlanta, and have been working, the work that I do is outside of Children's. So I've past 10 years, I've worked outside of the Metro Atlanta. And so now we are expanding to all of Georgia, which is wonderful. But as you know, Children's Healthcare of Atlanta has been dedicated to providing the best care possible to sick and injured children, and to helping kids stay healthy through our advocacy and our prevention programs. Those programs have been statewide for the past few years, and Children's recognized there was a need to expand even further. And so we were thrilled to go into a partnership with Mercer University School of Medicine and the Rural Health Innovation Center because we knew that they have the relationships with the community that we know is valuable, and that they hold the key to understanding how can we best help the communities outside of Metro Atlanta. And so we believe that together we can make a huge impact in the lives of children here in rural Georgia, and for now and for in their future. So, thank you.
Good morning, everyone. I am Kedrick Williams, and I serve at the Georgia Rural Health Innovation Center. Certainly happy to see each and every one of you all here. I have been asked to provide information regarding continuing medical education and continuing nursing education credit. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of the Medical Educational Council of Pensacola, MECOP, and the Mercer University School of Medicine. MECOP is accredited by the ACCME to provide continuing medical education for physicians. The Medical Educational Council of Pensacola designates this live activity for a maximum of 4 AMA credits. In accordance with the policies of the ACCME, MECOP has collected disclosures from the speakers and planners involved in this activity. None of the planners or reviewers associated with this activity have relevant relationships with ineligible companies to disclose. The speakers, as you see listed below, do not have any relevant relationships with ineligible companies. Continuing nursing education credit. Three Rivers AHEC is an approved provider of continuing nursing education by the Alabama Board of Nursing for a maximum of 4 contact hours. Nursing participants should only claim the credit commensurate with the extent of their participation in the activity. Three Rivers AHEC has collected disclosures from the speakers and planners involved in this activity, and none of the planners or speakers for this activity have relevant relationships with ineligible companies to disclose. Our first speaker for this morning is none other than Dr. Keith J. Mann, who comes to us from Chapel Hill, North Carolina, with the American Board of Pediatrics. He currently serves as Vice President of Continuing Certification for the American Board of Pediatrics. His academic appointments include being an adjunct professor of pediatrics at the Duke University School of Medicine. He was educated at Harvard School of Public Health, obtaining in leadership development, the University of Cincinnati, his degree, a master's degree in education, Harvard University School of Public Health, as well as the New Jersey Medical School, where he obtained his medical degree. Postgraduate training included pediatrics as chief resident of the Thomas Jefferson University and Al DuPont Hospital for Children in Wilmington, Delaware, and Philadelphia, Pennsylvania. His additional training is varied among various leadership development programs, leadership development at Children's Mercy, Kansas City, and the Human Interaction Laboratory of NTL Institute for Applied Behavioral Sciences. Ladies and gentlemen, I welcome to the podium at this time Dr. Keith J. Mann.
Thank you so much. I want to thank you, Kendrick, for the kind introduction, and thank you all for welcoming me here. This is my first time to Macon, and I got a chance to spend some time here yesterday. It's a gorgeous campus. Got a chance to drive downtown, have dinner. I always like to explore where I am locally, and really everybody from the people at the hotel through the people who I had dinner with last night greeted me warmly. So thank you so much. You might be wondering why is the opening talk about continuing certification? How does that fit into what we're thinking about today? And I want to say, previous speaker, Pamela mentioned the partnership between Children's Healthcare of Atlanta and you all here. Well, now the Mercy University and the Rural Health Innovation Center have a formal partnership with the American Board of Pediatrics. And I'll mention that a little bit towards the end of my talk today. So I'll start by giving an overview of who the American Board of Pediatrics is, kind of get some nuts and bolts of maintenance and certification. So for those of you in the audience that are pediatricians, try to help you see the program in ways that it actually can help benefit your practice instead of looking at the American Board of Pediatrics well, how some of you might look at the American Board of Pediatrics over time, your certifying body. And then spend the last 10 minutes or so talking about the fact that this group now is a pediatric portfolio sponsor and a partner of the American Board of Pediatrics and what that means for you all moving forward. So I have no disclosures. Here are some of the learning objectives that I hope we achieve today. And then so the agenda will be a brief overview of the American Board of Pediatrics, some nuts and bolts of maintenance and certification, and then what does it mean to become a pediatric portfolio sponsor and how does that benefit all of you? So the American Board of Pediatrics is made up of about 105, 107 staff and about 20 contractors. We have an office that's in Chapel Hill, North Carolina. It's smack in the middle of Duke and UNC. So this has been a great football season, and Final Four season is crazy. You do not want to declare your allegiances while you're on our site. Even 105 people can get pretty rowdy that time of year. But the reality is the American Board of Pediatrics is made up of pediatricians. We have over 400 physician volunteers. Those physicians make up a board of directors, general pediatrics committee. And so again, for those of you that don't know the board, it's pediatricians who write the questions for the initial certifying exam, pediatricians who write questions for MOCA Peds and continuing certification. We also have the 15 subboards for the people who write the questions for all the subspecialty exams. We have a family leadership committee, and then we have a bunch of other levels of involvement. So I run a continuing certification committee, and it's the people who give me advice on how to run a continuing certification program for the American Board of Pediatrics. About 3 years ago, recognized that in the 15 years of this committee, there had never been a rural pediatrician on the committee. So 3 years ago, we appointed our first rural pediatrician who comes from Eastern Tennessee. She's part of a 4-person practice in Eastern Tennessee, and she helps guide the continuing certification department where we work about what it's like to be a rural pediatrician and how we might be able to meld a program that would work more for people in communities that we had not been receiving feedback yet. So that's been tremendously helpful. I'll also say that just a handful of little things, if you're ever interested in volunteering with the American Board of Pediatrics, feel free to come and chat with me after this. It can be a big committee volunteerism, or the pediatricians also actually help set the standard for what comes to the exam. Every 5 to 7 years, we do something called standard setting, where we talk to pediatricians who take care of patients day in and day out and ask them what they do. And what they do and their estimates of the percentage that they do it is what ends up making it to our exams, especially the continuing certification exam. And so when you think about, some of you hopefully are in MOC Peds right now, which is kind of an online longitudinal assessment. We are seeing a lot of positive feedback about the relevance of those questions. So I think what we're getting is that the pediatricians that we were asking about what you do in practice is hopefully translating into the questions that you're seeing on MOC Peds. And then lastly, the pediatricians actually set the passing standard. And so the passing standard for each of our exams are set by pediatricians who look at the content and are working with us to figure out about what percentage should a pediatrician practicing get right. So the reality is American Board of Pediatrics is an office. It is 105 staff, but the reality is the American Board of Pediatrics are the pediatricians who volunteer with us, and we can't thank you all enough. We started doing more engagement outside of just our volunteers about 5 to 7 years ago, getting out more, giving more talks, engaging with local communities, especially AAP state chapters, bringing in people to do focus groups. And one of the first focus groups, we asked people what they thought of us, what they thought of the American Board of Pediatrics, and that's the word cloud you see on the screen. Some positive words, interactive, evolving. Evolving's mostly positive. Flexible. But then other words up there, intimidating, expensive, confusing, rigid. Most of you in the room don't know me. You might think of me in some of these terms if you knew me well, but I think most people who get to know the people at the American Board of Pediatrics, that's the last way we would ever want to be perceived. We want to be engaged with pediatricians. We want to be partners with all of you. And the reality is we are a certifying body, which comes with some expectations from the public, but we want to partner with pediatricians to develop a program that's meaningful and valuable to all of you. So our goal is to change this word cloud. I'm not ashamed of the word cloud because it's how we're perceived, but it's certainly not the way we want to be perceived long term. So then jumping into maintenance certification, what does the program look like and how do we want to evolve the program to make it more valuable for all of you, and what have we done so far? So there's several components to continuing certification. We're going to spend a lot of time talking about the second, third, and the fourth component. The idea of self-assessment, so learning and self-assessment. How do we work to make sure pediatricians are staying up to date with practice? How do we administer the ongoing assessment of knowledge, and what are the quality improvement opportunities look like? So this is a quick snapshot. Feel free to use the QR code. It jumps right to our website of what the requirements are for continuing certification. And so if you keep up one certificate, everything in the left side of the screen, the wheel, applies for no matter how many certificates you uphold. If the stuff to the right side of the screen, you take multiple exams if you happen to hold multiple certificates with us. But the idea is there's a certain amount of Part 2, which is lifelong learning and self-assessment, and a certain amount of Part 4, quality improvement, that's required. And then there's an exam component. And we've shifted that exam from a point-in-time proctored exam to an online exam, which is delivered quarterly and we believe is much more beneficial to pediatricians. And we'll go through all of that in a bit of detail. So starting with self-assessment. So there's components like 50 Part 2 points, and I don't like to think of things in points, but it's like CME hours in some way that we require over the course of 5 years. And we've tried to expand the opportunities to get credit So they're available to people all over the country. And so these are different ways that we offer ways to get Part 2 credit. So I'll fly through the first two and then spend a little bit of time on the third. So one is we partnered with the Accreditation Council for Continuing Medical Education. So most CME can also count for MOC Part 2. What it requires is that the local CME office or the local CME provider register the activity for Part 2 and have your ABP ID numbers. If that happens, you actually can get, so say you go to Grand Rounds and you're not currently getting MOC Part 2 for it, you can actually register, the local CME provider can register that activity and you get credit in the background. It actually passes through the CME offices just like any CME credit that you might have. That applies to things like UpToDate. So if any of you use UpToDate to search information and try to learn about the patients you're caring for, you can link your UpToDate account for CME, and you can also link that account for MOC Part 2 just with your ABP ID number. So there's relatively easy ways to get credit for your continuing certification world with some of the work that you're doing. If you keep up any of your resuscitation certificates, you can easily upload those for credit. And then if you're learning about diversity, equity, and inclusion in your work environment, you can simply attest to the work that you're doing and claim the amount of hours that you've learned. But what I want to focus on really is some of the activities we produce that we hope help you keep up to date with the medical literature. And the first is called Question of the Week. And so 50 weeks of the year, we pull an article, provide an abstract, write a single question with a 1,250 word summary, the same exact question a second time, and then key takeaway points. What we're asked over the years by pediatricians is don't just test me. Like, we know you're a certifying body, but we want you have a role to not just test me, but also help me keep up to date. And so this is one of the efforts that's out there. So here's a quick snapshot of some of the questions of the week in May of 2023. The one I will share on the screen is related to overuse injuries. There's a case study, which starts with a brief description of a patient. There's then a single pretest question, an abstract that's provided from the literature, a 1,250 word commentary, and then takeaway points. And then for those of you interested in looking at medicine outside the world of a typical case scenario, there are medical pearls, which are really well written. I often skip them because I'm doing something else. But for people who love medical history and literature, the medical pearls are absolutely fascinating. So this is a kind of a typical case study. And then key takeaways. So you can find question of the week within your ABP portfolio. The first time you answer a question correctly, it will then email you the question of the week every week into your inbox. You can ignore it. There's no requirement to do any certain amount of questions. Some people do 1 a year. Some people do 50 a year. So there's 84,000 certified pediatricians, and about 30,000 now are signed up for question of the week, and about 10,000 do it on a regular basis. And we typically get almost universally positive feedback on this. So easy way to keep up to date with the literature, learn about 50 new articles each year, and then it's really geared towards general pediatrics. So we hope it helps you in your practice. The second thing we've worked hard on is an activity called Decision Skills, and it's supposed to, the goal is to help with clinical reasoning. They're case-based studies in a multiple choice format, similar to an exam, except that we can do a lot more when you're not in an exam format. So the cases are a lot longer. There are often multiple laboratory studies and/or diagnostic studies built within the case. And it's really, again, meant to think through clinical reasoning. We used to have just the forms, like a 50-item form or a 25-item form like you'd produce for an exam. And we recognize that nobody wants to, I shouldn't say no, most people don't want to spend time going through a 50-item form anymore. And so we've broken them up into things that you might want to learn. And so during COVID, we produced 10 questions around COVID, which we hoped would help stimulate learning in that environment. We have one for behavioral mental health, endocrinology, hematology, oncology. We're working on one right now for cardiology, and I think we just released one last week for infectious diseases. So these are 5 to 10 questions on a topic you might be interested in, and you can just delve into clinical scenarios, answer some questions, and then try to learn. And again, all of this kind of applies towards your continuing certification credit. And then lastly, we produce article-based self-assessments. And again, with the idea of trying to help keep up to date with the literature, we try to produce article-based self-assessments in areas that are relevant to general pediatricians. Knowing that you also have a DEA requirement that just came up last summer, this is one that's about adolescent substance abuse and mental health. So it's a self-assessment. I think this one has about 7 to 8 articles pulled from the current literature with about 20 to 25 questions on a topic. And so again, the goal is to help keep you up to date. And then with this one specifically, you can get CME, partial credit for your DEA, and then also credit for MOC. So we're trying to link things so you can do multiple things with more impact. So now jumping into MOCA Peds, which is our online proctored exam. And so again, for those of you that aren't physicians in the audience, for once you pass your initial certifying exam, the expectation is ongoing certification. And one of those expectations was an exam at a proctor testing center every 7 to 10 years. And the feedback regularly was, I don't want to go to a proctor testing center for the rest of my life. It's not valuable. I cram, I don't learn. And it's that's not an environment that's conducive to ongoing certification. And so back in 2018, we piloted an online longitudinal assessment, and that is now standard practice. And so what is MOCA Peds? So the goal is to focus on assessment and learning. Again, don't just assess me, help me keep up to date and help me learn. And so it's up to 17 questions get delivered each quarter for each certification area. It can be either via your laptop, desktop, or a mobile device. You take the 17 questions, one question at a time. Once you take the question, you actually then get the answer right away. Actually, you rate the question to your relevance, how relevant it is to your practice, and how confident are you that you got it right or wrong. You get the answer, and then you get a 1 to 3 paragraph summary of why the answer was correct or incorrect with references. You take those 17 questions each quarter over 4 years, but we allow you to drop your 4 lowest performing quarters. So whether you skip a quarter, don't do well in a quarter, or decide just to crank right through, we'll always drop your 4 lowest performing quarters. So you can imagine if it's a 4-year exam, 16 quarters, and you just crank right through, you do the first 3 years and you do well, we'll give you your score at the end of 3 years and let you know you've passed, and then you have years 4 and years 5 off of your cycle. So the idea is it's meant to work into practice in a way that's much more compatible than a proctored exam, and then hopefully much more valuable. So we also introduce 1 to 4 new articles per year. They're chosen by experts in the field. We ask that you don't work with a colleague. It is an assessment of individual knowledge. That's our responsibility as a certifying board, but you can use resources. So I pull up to date on one screen, and then I have my questions on the other screen. We give you repeat questions. And so of the 17 questions per quarter, so you get about 70 per year. There are about 10 to 15 repeat questions. And so if you've gotten them wrong, or if you've gotten them right and rated them highly relevant to your practice, we'll feed them back to you. Again, the goal is not to trick you. We're not trying to fail people on an exam. 98, 99% of people who do all the questions pass MOCA Peds. The goal is to help you learn. So it's the concept of spaced repetition learning, where if you see something that's relevant to you, you will then subsequently learn it and incorporate it more if you've seen it a second time. And there is the option to still take the traditional exam if this isn't for you. So this is a quick snapshot of what it looks like. There is a question, the rationale right afterwards. You can bookmark a question. So again, you can go back and look at your question history. So if you've gotten a question wrong, bookmark it. Go take a look at it again, because you'll see it again. Question 2, 3, or 4. Sorry, quarters 2, 3, or 4. You're likely to see the same exact question again. There is information in the screen about your question history, as I mentioned. And then also exam content and your performance. You can continue to look about how you're doing, and you can look at the learning objectives in advance and the articles in advance. On our website, we have a dashboard that shows the data for MOCA Peds. It shows all the passing rates. It shows all the relevance ratings. And so there's nothing, we don't keep anything about this secret. Like, it's all out there for you if you wish. I'll just show you a little bit of the data that we have. So we ask pediatricians, did you learn enhance your medical knowledge based upon taking MOCA Peds? And you can see the graph to the left-hand side of your screen. And so between 87 and 92% of pediatricians enhance their knowledge via MOCA Peds. And then about 65 to 70% apply what they've learned to their practice already. The remainder of that gap, about 10% say, I haven't applied it yet, but I can think of ways I will. And then about 15% are subspecialists taking general pediatrics who actually say, I'm either not practicing in the field or not practicing at all. And so the majority of people who are taking MOCA Peds both learn and then apply it to their practice if they're clinically active. And they apply it to their practice in multiple ways. The first graph says, I learned something specific. So the first graph is what we expected. I learned something specific. And I learned it in a way that changed the way I practice. I prescribe a different medication now for pneumonia. I used to prescribe a more broad spectrum, and I've narrowed it down to amoxicillin. Or I diagnosed Kawasaki disease. I hadn't seen it in private practice for 10 years, and I just had a question on it, and it was great. The timing was perfect. I diagnosed it the week after. The next couple columns are the ones that even intrigue me more. They've changed the way people practice. I look up articles more. I search the literature more. I'm practicing more evidence-based medicine. I'm engaging with my patients differently. And that's what I really want to see. The reality is the goal of any certification program is to stimulate pediatricians who are thirsty for knowledge and interested in caring for patients and interested in improving that care to do so within the context of a productive partnership with their certification board. And that's what, so I'm really intrigued by the other bars that suggest people are making these metacognitive changes to the way they practice. So I'll jump into the last one, quality improvement, and then wrap up with discussing you all being a portfolio sponsor program. So first, people ask me all the time, is there any evidence to support quality improvement as a component of continuing certification? And I'll be honest, the evidence isn't great, but I'll share the evidence that exists. So the first is, if you're ever interested, a paper published by David Nichols, our old CEO, does a really nice job of summarizing all of continuing certification. It was published in Pediatrics in 2017. It's a nice article to breeze through, but it summarizes the idea of professionalism in the context of self-regulation, which is what we are. We're a self-regulating body as a field of pediatricians. So in that study, in that paper, though, he summarized the impact of which QI studies and MOC is awarded, and he cited over 30 studies in pediatrics which support the association of MOC Part 4 with improved care and the importance of MOC credit as an incentive. And please know it's not cause and effect, right? It is truly just an association. So it's a weak body of evidence, but that's the evidence that exists. I think the thing that's most powerful, though, is the second part of it, which is the importance of MOC credit as an incentive. And since that article has been published, I just pulled 4 more that we've seen recently that talk about the value of MOC as an incentive to engage pediatricians in quality improvement. And then the goal is, from being engaged in quality improvement, people find a passion to improve the care of the patients that they are engaged with. And that's a lot about being a portfolio sponsor organization, which I'll get to briefly at the end. So our goal is to make this QI component more meaningful, less time consuming, less burdensome, and more relevant to all of you. So how have we thought through that? The first, and so this is just a slide that shows the different ways to get your credit for continuing certification for quality improvement. All the way to the right of the screen are our online performance improvement modules. This was the old hand washing module that we got a lot of flack for. 22,000 people used to do our online performance improvement modules back 7 years ago. That's now down to about 5,000. So about a 63% decrease. That's a purposeful approach. The old modules used to get a lot of flack. I think they were relatively well built, but there wasn't any possible way to have enough modules that pediatricians could do. So people were just going through an exercise in futility, going through an exercise to check a box for continuing certification, which is, again, the last thing I would ever want to have happen. So as the numbers went down from about 23,000 to about 5,000, the relevance ratings have skyrocketed. And so the relevance ratings are now up in the 92 to 95% range for all of our modules, because I think people are doing them because they find them relevant to their practice, not that they have to. We still get feedback that there's not a lot of other options, and I'll share with you some of those that exist. So to the left of your screen are large-scale QI projects. That's mostly for subspecialists. Like Improved Care Now is a big network for GI docs who care for inflammatory bowel disease. But there are some for general pediatricians. There are several AAP state chapters who run large-scale collaboratives, South Carolina and Tennessee being 2. But again, most commonly, pediatricians are getting credit from the second or the third box. The second box are workplace-based QI. I'm doing something in my workplace, and I'm able to get credit for it. One is you can apply directly to the American Board of Pediatrics, but there's an extra step in there. You have to take your work, fill out an application, apply through us. I'll show you the criteria for that, but it's an extra step. 103 organizations now, congratulations, you're the 103rd, are actually giving credit on behalf of the American Board of Pediatrics. So we partner with organizations, so the QI work happening locally, you can all get credit for. And that's what it means to become a portfolio sponsor. And again, I'll wrap up with that. If you're part of an NCQA patient-centered medical home or any other patient-centered medical home now, you can actually get credit for that partnership. So here's just a brief snapshot of our requirements. If you happen to know quality improvement well, you'll look at these requirements, and quality improvement experts want us to always strengthen them. The reality is we know half of general pediatricians have never been trained in quality improvement. And so the requirements are pretty straightforward. There's got to be a known gap in care that you've identified, some intervention, a single measure, and a couple points of data to say that there's been some effort to improve over time. Nice thing is you can get credit. One person can do an application and 10 others can get credit. And we do have some coaching. If you've never done quality improvement before, reach out to us. I spend probably a day or two a month chatting with practices about how to do quality improvement in their practice. And I'm happy to help in any way. We also have a staff of people who are happy to help in any way. This is just an example. We're talking a lot about mental health today, so I wanted to pull a mental health example for all of you. This is from a rural practice of, I think, 4 or 5 pediatricians. They had identified depression screening as a gap. They implemented improvements in depression screening and got their screening rates up, I think, to about 90%. That was their first application. But in improving their screening, they recognized that only 4.5% of their screens were positive. And they said, there's no way. We know just from being in our community that the rates of depression are higher. And so they regrouped and said, well, if we're going to screen, we might as well do it effectively. And then you can see their measures, a series of interventions, all designed to improve the quality of their screening measured by the percent positivity. They were estimating that they had about a 10% prevalence in their community of pediatricians, of patients, and we're trying to up their rates to come closer to that. And you can see they did this over the course of several months, and they almost doubled the percent positive rate. And again, the goal is not to double the rate. The goal is to get a more accurate reflection of what's actually in your community, and they were really proud of this work. The last thing I'll mention again, to try to link this to some of the behavioral mental health topics today, we also have modules or templates that are available for you if you don't know what you want to do in QI, but you recognize a gap in the behavioral mental health care that you're providing. And so this is a roadmap project, and it was designed to help support the emotional health of children and their families specifically with chronic diseases, but it can apply outside of that as well. It's a really fascinating project developed with pediatricians who care for children with chronic diseases and the families of those kids, partnered together to develop this template. It's about the simple ask to, when you're engaging with patients with chronic disease, to not forget about their mental health. Simply asking, the parents, how are you doing today? Asking the child, how is your mental health? How are you adjusting in school? Making sure that the mental health side of children with chronic diseases is cared for as much as their physical health. We're just writing up early pilot data from this from this project, and so far the results are really promising. We hope to publish them in the next year or so. But again, the engagement level of pediatricians in this has been outstanding. So what does the future of Part 4 look like, and how do we continue to make it more applicable for people? So we want to make it easier to get credit if you're already doing the work. And that's the icon on the left and the icon on your upper right. And then we want to grow a program so more meaningfully things count. I'll start with growing a program. What I always know as a pediatrician, but we never really reflected in our program, and it became much more obvious during COVID, was the amount of time pediatricians spend advocating for health in their communities, going out to their communities and understanding where the gaps in care are and closing those gaps, recognizing there's food insecurity and working to open up food pantries, recognizing that there's a mental health problem and working on some sort of screening in a school-based system. And so starting next year, there's going to be a new pathway for community health initiatives to give credit for pediatricians engaging in their communities, not just with traditional QI methodology, but getting boots on the ground work. And we're looking forward to launching that in the first quarter of next year. Then the other, though, is to fuel collaboration. The improvement work happens locally. If you're doing that work locally, like the American Board of Pediatrics should accept that local work. And we do it through this idea of portfolio sponsorship. So I just want to just first say congratulations again to the Mercer University School of Medicine and the Georgia Rural Health Innovation Center. You have become our 103rd portfolio sponsor organization. So welcome as a partner. You didn't know you were partners with the American Board of Pediatrics, to a wonderful group of 103 organizations that partner with us to improve child health. This is a picture from a conference. We host a conference once a year. We invite portfolio sponsors up to the Chapel Hill, get to know us and present posters and share work. So we partner together. So what is a portfolio sponsor organization? It's organizations that can evaluate their own QI projects against kind of standards and approve those projects locally, and then award credit to engaged physicians. And so the whole process of getting your MOC Part 4 credit can happen outside the walls of the American Board of Pediatrics. It can happen locally. And that's the goal, because improvement work and the work you're doing in your community happens right here. This is the growth of the portfolio sponsor organizations over the last 5 years. The biggest emphasis since I started about 5 years ago was expanding it outside the walls of children's hospitals. So early on, most of the portfolio sponsor organizations were children's hospitals. Over the last 5 years, we now have 3 or 4 large clinically integrated networks. There's 5 AAP state chapters, and we welcome you all to that group. So what's the data look like from our portfolio sponsor organizations? So in 2022, if you look at Part 4 or QI completions, excluding kind of some online modules that we host, so this is just the work happening where somebody's submitting an application somewhere to get credit for it. ABP portfolio completions, and completions, we say completions, it's not necessarily physicians. One physician could have submitted 2 projects. So 6,037. The American Board of Medical Specialties has a multi-specialty portfolio, which actually approves it for almost any medical specialty, and we partner with them as well, so another 3,400 through them. And then all other completions were up and around 96, 76. And over the last 15 years, the data looks pretty similar. So about 50% of pediatricians doing QI work are getting credit in their local environment, not through the American Board of Pediatrics, but peripherally. And so we encourage you to use this to the best of your ability. You should never have to submit your work to us again. It all happens through your local organizations. And then just to give an example of 2 longstanding portfolio sponsors, Nemours Children's became a portfolio sponsor in 2010. They've since approved 72 projects and over 1,000 completions. And then Lurie Children's as well, 68 projects and over 1,000 completions. So again, we're really proud of these relationships, and it's some of the best work, most exciting work that we do is partnering with these organizations. So what are the benefits we hope you all get from this new designation? We hope that you can align your local efforts to improve care and the credit for those who are participating in that care. Integrating quality improvement into practice. So once this idea kind of starts to take hold, we hope that quality improvement becomes part and parcel of what happens in practice, because there's a set of resources available and time spent to drive care. And we hope there's organization at the community level. Community identifies a gap in depression screening, suicide screening, and the community can tackle that together. The group can get credit for it together, and it's not an individual practice based. You actually can drive care in your community. We've seen that happen time and time again. We hope, again, that it sparks interest in quality improvement in a way that drives the natural intrinsic motivation pediatricians feel to provide outstanding care. I don't believe quality improvement is a not popular standard at times because pediatricians don't care about the improvement of their patients. I think it's a not popular standard because it can be cumbersome to achieve. The goal is to make it easier to achieve. And at least I'll say this goes back 15 years, but when I first started getting involved in quality improvement, I didn't know what quality improvement was. I had the foggiest idea. And I found a career in it. But I didn't find a career in it because it was academically interesting. I found a career in it because I was passionate about improving the health care of kids. And I found a way to do that within the confines of what my job was. And I hope you all find that same passion, and you actually can find quality improvement as a vehicle to do what I know you want to do already. You can, again, mobilize a large group of people to make a difference and then minimize the cost and burden to pediatricians of getting that work counted in your continuing certification program. So I hope all of that is valuable to you all. And I'll just wrap up with this slide. If you ever need help as pediatricians, we also have a group of people that is always there and willing to help. This is just an example of a quote that we just got. They don't all look this wonderful. We get some bad quotes, but we do measure our customer service. We have about a 4.7 kind of satisfaction rating for our customer service work. But this is the most important thing. I put this quote up there is because it's the last line. Pediatricians take care of so many people. It's so nice when somebody really takes care of us. And that's our goal when you call for help. We want to help you through your careers. We have a responsibility as a certifying body, but we want to partner with you and uphold that responsibility. It doesn't have to be one or the other. So thank you so much for your time today. It's a pleasure to be here, and I'm happy to answer any questions that any of you might have.
Good morning, everybody, and good morning, Dr. Mann. Real quick, I would just have a question.
Sure.
Specifically in pediatrics, what are some challenges that you face outside in the community, whether it be just health disparities? I remember you talked about outreach in the community or things of that nature. What are some challenges that you face, and what are some things, honestly, that you wish that the community could be more engaged? Because I understand that you're only just one person, and it's a group collective effort. So what are some things with your expertise that what you would recommend or challenges?
Yeah, I think that's a great question. Thank you so much. I would say probably the biggest challenge right now facing the field is the mental health crisis and the fact that the training environment that many of us went through didn't necessarily teach us how to care for patients with mental health in the communities that we're providing care. The training, again, for those of you that are not pediatricians, the training for many years is often based in the hospital setting, critical care time, and the behavior mental health component of that training is small. Yet you go out into the community and 25 to 50% of what you see, depending on the practice, has a behavior mental health component to it. So I would say one of the biggest crises we're facing right now is in that field. We recently did a study that looked at the competencies of people graduating, and in a way that wasn't tied to their certification, tried to assess the competencies of people graduating and their skills to provide behavior mental health to the community, and less than 50% of residents are graduating with what they perceive as the competency to do that work independently. So that's one. And I think that is true, and it's disproportionately impacts underrepresented minorities. So I think there's an impact across the entire field of pediatrics, and I think there's a disproportional impact to underrepresented minorities. You asked specifically about issues with disparities. So I think that's probably the biggest crisis we face right now. And if I had to pick one thing, that'd probably be it.
Thank you for your presentation. What's the ABP doing with regard to recruiting young women and young men to pediatrics as a specialty?
Yeah. Fantastic. So I don't have a great answer to that question. I will say it's a wonderful question, and it's one we're pondering. So the National Academies of Sciences, Arts, and Medicine just released a 50-page kind of consensus paper on the pediatric workforce about a month ago. And the conclusion in that paper was that there's a workforce problem in general pediatrics, but also in a ton of pediatric subspecialties. About half of the pediatric subspecialties, there's a significant workforce problem, and they are tied to the pediatric specialties, which pay less, unfortunately. The pipeline going into so the answer, people often look to us and say, "What's the answer?" And a portion of that paper asked the American Board of Pediatrics and the Accreditation Council for Graduate Medical Education, the group that oversees training programs, to shorten fellowships. One of the considerations was should you shorten fellowships to 2 years? The answer is we should consider that. We should think about the pros and the cons, and we're in the process of vetting that with a lot of people. But I'm not sure shortening fellowships to 2 years is going to solve the workforce problem. I think it might solve other problems. We might enhance the recruitment from people who are tons of money in debt if you shorten fellowships, but I don't think it's going to magically solve a workforce problem. So when we look at the information that we have, the pipeline coming in, so your question is perfect, because the pipeline coming into pediatrics is flat or decrease over the last bunch of years. And so there's no way to increase, for me anyway. We could tweak the numbers of years of fellowship, but if the pool coming in is exactly the same, you're just shifting from one to another. Somebody might be going from one fellowship into another, or from general pediatrics into a subspecialty. It's not changing the overall paradigm of the workforce. The American Board of Pediatrics hasn't traditionally worked or partnered with medical schools. It's the certifying body. We partner with training programs, but you're already in pediatrics there. We partner with pediatricians, but they're already in the field. And so a question on our mind now, I don't have the answer yet, is how does the American Board of Pediatrics work better within the field of pediatrics, the house of pediatrics, to begin to drive interest in the field earlier? And if we can do that, we then have to increase training programs and think about length. And we have to do all of this in conjunction. But I'm not sure any of it matters if we don't increase the pipeline, because then we're just shifting the chairs around on the deck as opposed to actually changing the true workforce dynamic. So your point is very well taken. It's the approach we need to take. It's just not a place we've gotten to in the past. So thank you. Yeah.
Thank you. Hey, I'm Dr. Odegaard, Family Medicine. I was just wondering, with the recent sort of increased push towards pediatric hospital medicine as a required fellowship training, do you think that from the perspective of the Board of Pediatrics, that has increased the quality of care or reduced the access of care in rural healthcare situations where fellowship training may not necessarily be a feasible option?
Yeah, great question. And so again, I'll just give a brief amount of background. You go back 5 years ago, and you graduated from a general pediatric residency, and you could practice without fellowship training in hospital settings or primary care settings. You can still do that, but there is a fellowship pathway now for hospital medicine, and subsequently a board certification option for hospital medicine. And the concern in the communities is that as that unfolds, will hospitals require those doing fellowship to staff hospitals, and might that decrease the access in the rural environment? So the short answer is we don't know yet. So the push to have hospital medicine as a subspecialty came from hospitalists. It was so the American Board of Pediatrics we have a stake in who we certify, but anybody new it never comes from us. It's proposed by the discipline, and it was a discipline that was felt very strongly that board certification was critical. And since that time, there's been a lot of question at the discipline level, not just with the American Board of Pediatrics. Like, was this the right thing to do? And some of it gets down to the questions that you're asking. I'll say we don't know the answers yet to whether or not outcomes are better. we don't believe there's been any impact yet, at least kind of networking with local communities. There's still plenty of people that are being hired to do hospital-based medicine without fellowships. We believe that's going to continue, but there's no way to know for sure. So I think it's too early on in the journey to reflect on that yet. I think we're 2 years into certifying hospitalists now, 3 years into certifying hospitalists. But great question, and one that we'll keep an eye on.
Dr. Weeks, I'm family medicine also. My question was specifically related to the practice of pediatrics in rural settings. Pediatricians in and of themselves, while they usually are the lead of that, are not the only people caring for pediatric patients. Family medicine, nurse practitioners, yep. PAs. In regards to the fourth section and quality improvement, is there an avenue or a way that those pediatricians can work with nurse practitioners, family medicine doctors, and we all get credit for the QI we all get credit for that QI work. I have to do that for my boards. I know nurse practitioners and PAs probably have something similar. Is there any way under the way you have it set up that yep. they can work together? Yeah, absolutely. So a couple of things. So one is the American Board of Family Medicine does participate in it's called the American Board of Medical Specialties multi-specialty portfolio. That's not the portfolio that this was approved as a pediatric portfolio. I'm actually traveling to Lexington next week to chat with my colleagues at the American Board of Family Medicine. I'm going to mention this example and see if I don't know if they'd be willing to accept pediatric portfolio designation for their projects, or if there's a way to do that. But we partner with them a ton, and I will ask them that question. But happy to take a card or get your number and name and reconnect with you. But the other is they do have a lot of pediatric kind of credit modules that exist, and there's likely a lot of overlap that's possible in between. But I will take your question to them, and I'll see them, I think, Thursday and Friday of next week, or the week after, first week in November. Great. And I'll find you after that lunch, and we'll exchange numbers. Thank you. Okay, here's a real softball. Is Riley Leonard healthy, and can Duke beat Louisville? I'll say Riley Leonard does not look healthy. Apparently they say he's healthy, but he looks a little bit hobbled. And I don't know enough about Louisville football to know if Duke can beat Louisville, but since I live in the area, I'll say absolutely yes.
Thanks for coming. I'm also family medicine. Great. And so I was going to ask the question before you said you were going to meet your colleagues next week, is what is the American Board of Pediatrics doing? Are you collaborating with the AAFP in any way on some of these grand projects, and which ones? Yep. And then definitely, I agree with you, mental health crisis is the biggest thing that I face in rural medicine. And are you guys working together with AFP and the pediatric boards to address that issue, and how? Yep.
So I would say some of my best colleagues in the boards community exist at the American Board of Family Medicine. So we chat all the time. Their current CEO, a guy named Warren Newton, was the chair at UNC for a number of years, so we knew him locally. So the answer is yes, we collaborate with them all the time. We probably chat once a month and visit each other probably once a year. The collaboration extends several ways, but one is just the simple platform that we host activities on, we share. And so if they have an activity that we like, they just give it to us. And vice versa, if we have an activity that they like, we can give it to them. And so there's the ability to collaborate relatively easily that way. I like the idea of the ability to potentially get this portfolio sponsorship going in a way that allows family medicine docs in communities like this that are working with hand in hand with pediatricians to get credit for the community-based QI work that's happening. Because that, again, makes it seamless. And we'll see if that exists or is a possibility for them. And I'll follow up there. Great. Again, thank you all for welcoming me today, and I look forward to chatting with some of you over lunch in the breaks.
Well, certainly, Dr. Mann, we thank you so very much. We have a small token of appreciation for you, and that was presented by Ms. Lauren Brooker. Lauren is one of our Children's Healthcare of Atlanta scholars from this 2023 cohort. So thank you so much very, very much again. At this time, we are quite privileged to have some remarks given by our very own Dean of the School of Medicine, Dean Jean Sumner. Dean Sumner is a member of the School of Medicine's first graduating class and is a former physician who has practiced in Washington and Johnson counties. She has led the way in a number of significant initiatives here at the School of Medicine and beyond, including a major telehealth initiative that is a component of our Children's Healthcare of Atlanta partnership. She's a 1986 graduate of the School of Medicine. She has served in an array of different positions here at the School of Medicine, including community faculty preceptor, professor, and most importantly, our dean. At this time, Dean Sumner, if you would come to present on the importance of rural pediatric care.
Thank you, and thank you, Dr. Williamson. And I am so happy to be here. I know many of you, and so I'm probably not going to say anything that you haven't heard me say 100 times. Rural medicine is really important, and really good doctors and nurse practitioners and PAs practice in rural communities. And I spent my life there. I believe in it. I've watched the miracles that happen in small towns, and Mercer is a school committed to rural health. The most underserved population in terms of people who come to medical school are young people who grew up rural. The average across the country is 4.3%. We approach 50% of the students who are rural. And that, I think, is one of the highest in the nation. We have 70% outside of metropolitan Atlanta. Now, we love Atlanta, but people who grew up in Buckhead are not going to Hayhira. So we really focus on our mission. There's a science to rural health that's often overlooked in academia. You have to have a broad range of skills. You see amazing things that walk in your office that people often in tertiary care centers see after they've been through several levels of care. So you are so valuable to the outcomes of this state, and we appreciate you. We're here to help you. I noticed they gave me the topic of how badly we need pediatricians, and I'm an internist, but I'll be the first to testify. We need pediatricians. Georgia has 120 rural counties. 63 of those do not have pediatricians. And the counties that do have a pediatrician, I don't know any that have too many pediatricians. Family medicine is critically important to the care of children as well. So we appreciate you guys being here and taking part. We're trying to build a system of care. Now, through our relationship, we're extremely honored to have a partnership with Children's Healthcare of Atlanta. And it is a 10-year commitment. And many of you have already been approached to be part of that initiative. And it includes not only improving emergency care for pediatricians and giving opportunities in physicians' offices to consult with a tertiary care center or even a pediatrician in the next county. If you're a family medicine, you want to get a pediatric opinion, you can consult through high-quality telehealth because you can actually examine the patient, look at high-resolution cameras. We do mental health. We've done a pilot and a pre-pilot in 2 counties that we finished this summer, and we'll go into a full pilot on mental health screening. We have the potential for an autism project working with Children's and Marcus Autism Center soon that will come into a rural county, which is an amazing center. And then we also, through the generosity of Children's Healthcare, last year we started the Children's Scholars. Lauren, of course, is one of those 10. We have 10 free rides, full scholarships for 10 pediatricians every year for 10 years. That will live and work and practice in a rural community. In Georgia, that's a county of less than 50,000. This year, Children's has announced they will have 10 scholarships for family therapists who will work with those communities and live and work in there to provide care for children in those communities and their families, which I think is a game changer. I think that this project allows us to transform rural Georgia. But the secret sauce is you guys. We want to work with you. You're doing the work. I've been out there doing the work. It is hard. I can tell you 1,000 stories. I will not bore you. But people who don't understand the importance of your presence in these counties need to come and see your work, because you save lives and you prevent illness. And care is transitioning to communities. You see that certainly in adults. When I was a student, you stayed in the hospital 2 weeks if you had heart surgery, or 3. You stayed in there 10 days for your gallbladder surgery. Now you hardly stay 10 minutes. And who takes care of you when you get home? Your local doctor. And the patient, you say, who took care of you in the hospital? And a lot of times they go, I don't have any clue. A lot of people came in. We don't know. So we've got to improve that system. We need community-based care. And these rural communities are vital to Georgia. You produce the wood, the fiber, the vegetables, the corn, the thing that feed Atlanta and the rest of the world. And so industry does not come to areas without health care. You will never break the cycle of intergenerational poverty without good schools and good health care. And good health care brings good schools. It brings better performance. Pediatricians and family medicine doctors who really take care of children are so important. There's a proverb that you've all heard: you raise up a child in the way he should go, and he will not depart from that. I don't think the Lord was talking about pediatricians when he did that, but I think of that often. If you start them out right, even the most uneducated family, or the dysfunctional family, or the poorest family, cares about their children. Mothers care about their children. Daddies care about their children. If you can get them to understand what that child needs, you motivate the family to do better, and the family does better, and there are huge ramifications across the whole spectrum. So I'm here just to say thank you. We're really proud to be a portfolio site. We'd love to partner with y'all on figuring out how to integrate some of these projects, because there's no way that you can have enough pediatricians in rural Georgia, and there's no way you're going to have enough family medicine doctors, really. MRSA has lots of, we're completely devoted to our mission. Most of you know we get funding from the state of Georgia, and we're NIH Center of Excellence in Rural Health. If there's a way that the school can work with you, your practice, or the center, which I think of us as one and the same. Glenda's going to get me for doing that. But the center was placed here by the state because of our mission. We take that mission very seriously. And when we call, and I've been in rural Georgia, when people call and say, we're here to help you, and you go, yeah, right. Where are you calling from? So I get the opportunity to call people around the state this week, and some people call back. Because you know somebody that knows somebody that gets them to call you back. When we come into your community, we're not there to replace you. We're not there to bring some industry to take away your business. We're there to help you survive and help you get the things you need. So please feel free to reach out to us, the center. We're there to help. We appreciate your being here today. We are deeply honored by our partnership with Children's. Deeply honored. And I can tell you, we are 1,000% committed to raising the care for children in this state. I don't know how many of you read the Wall Street Journal. I get it occasionally. My campus dean here brings me his paper copy that he told me the other day was going away, so I don't get a free paper anymore. But there was an article on the front page of the Wall Street Journal about the ER care for children in this country. I'm an internist, so you have to consider that I don't know all that data for sure. But when I read through that article and then read some of the responses to that article, this children's project is ahead of that curve. We've been laying a groundwork for the last year, and you're about to see it expand. This year we'll add more hospitals, more pediatricians, more mental health services. So please let us know how we can help you. And we would love to work with you. So thank you for being here, Dr. Mann. I enjoyed your presentation very much, and we're glad to host you. And if you have any problems or needs, let me know. Thank you.
you.